Hello, everyone. I'm Dr. Patti Peeples, and welcome to the next episode of Patti's People, sponsored by the Evidence Base. Today, I'm absolutely delighted to welcome my guest, Dr. Michael Drummond, Professor Emeritus and former Director for the Center of Health Economics at the University of York in the United Kingdom. His main field of interest is the methodology and practice of economic evaluation in healthcare. He's educated most of us with the authorship of two major textbooks and more than 750 scientific papers. We're going to talk a little bit about how he has advised several governments on the assessment of health technologies and acted as a consultant to many life science companies in the HEOR space. And in 2010, he was made a member of the National Academy of Medicine in the United States, and he served for 14 years as co-editor-in-chief of Value in Health and was recently made editor emeritus in May 2024. Welcome, Dr. Drummond. It's really nice to have you here.
Thanks for having me.
We're going to talk about a variety of issues, but I want to start out by one of the most common and intransigent, it seems, debates that we have in the health economic space, and specifically whether or not health economists are moving into an actor in public policy, or are they an observer or arbiter? With health economists, and really like yourself, being closer to the power center than ever in advising policy, pricing, access, and national decisions about what gets funded, what do you believe the role of the health economist is primarily still is? Is it to inform policy, or has the field quietly edged over into shaping it? And where should we draw that line, if at all?
Yeah, well, I think the short answer to your question is that I think we're still in the inform bucket. Many of us have participated in committees where we provide scientific input primarily, either at the committee hearing or with papers in advance. But obviously, once you get into the discussion, you can exercise your opinion, and I'm sure that some of the economists in the UK on committees from our National Institute for Health and Care Excellence do express opinions from time to time. But I think my feeling would be I'd like to stick to the science when we're in these meetings. So if we have something to say, it should be informed by evidence that we're aware of, not just pure opinion. Now, I guess in the heated discussions, one might stray away from that. But my mantra has always been stick to the science, because that's the distinctive thing we add, along with other professionals, of course, where there's lots of opinion about. It's something that's backed by evidence that is important in my view.
Maybe you have a real life example of this, but how can economists help policymakers understand these alternative options and opportunity cost for policy decisions without drifting into advocacy? Might that look like?
Might be good to make a few examples, though. Outside of pharmacoeconomics, one of the best examples is the work in the US by Ellen Enthoven, who really pioneered the idea of managed competition, which was influential in a number of countries, including the UK. I think within HEOR, one example might be in situations where economists have been part of the committee, but have put forward suggestions for maybe a policy change that should be considered. And the one that stands out there, I think, is the role of some of the economists from University of Washington who were on the formulary committee for a large managed care organization in the Pacific Northwest, and worked with them to develop a a formulae where the tiers were based on value for money rather than just simple, generic, non-generic, that kind of thing. And they piloted that, and it was quite successful. So I think being on the committee, getting to know the policymakers, and they get more trust in you, does give you that opportunity to put forward a few ideas for what should happen. So I think, as you say, that our main mantra is opportunity cost. And so people are always, in any situation, happy to talk about benefits. And maybe our role is to remind people that there is another side to these decisions where, in many situations, particularly when budgets are limited, something may have to be given up or sacrificed in order to get the benefits from adopting the new therapy.
So let's talk a little bit about the value debate. Despite decades of methodologic refinement, much of which you've participated or led, the debates about value in healthcare continue to be as polarized as ever, wouldn't you say? And initiatives like HEMA, which is the collaboration between NICE, ICER, and Canada, uh, versus USC Schaefer, in the debate about what value is, has exposed the deep philosophical divides rather than purely technical or methodologic agreements. Can you first, for our listeners, frame the sides of this debate and then espouse whether or not you think that we have reached a genuine standoff on this value debate, or have we just simply arrived at the place where we agree to disagree?
Yeah, well, in terms of framing this, I think it's worth remembering that there are other initiatives in this space. For example, the ISPOR task force and the ISPOR value flower, which partly underpins some of the work at USC Schaeffler. And also there's the work by Chuck Phelps and Darius Liquidella on GRACE, generalized risk assessed cost effectiveness analysis. So that it's all kind of mixed together. And if I were to sum it up, I mean, if you were talking technically, you'd say it's a debate between welfareism and extra welfareism, which is something which was developed in the UK by Tony Collier as a way of trying to put a theoretical, cover on what we were trying to do through NICE at the time. Or you might say it's a debate about individual preferences versus collective preferences.
Mm-hmm.
So is it a standoff or not? Well, I think the first thing to say is that both of the groups have a very good logic within the way they define the world. So you can't fault either group for being shoddy or slapdash. They're both really tried hard to think things through, given the perspective that they take. But I guess there is this difference between imagining a world where consumers should really be sovereign and exercise their preferences versus a world where the provision of healthcare is more on a collective basis, where we get money from people primarily from taxes and put it in a big pot and then decide how much of that to spend on health and healthcare. So it's different in that sense. I think there has been some overlap of thinking, certainly from the time the ISPOR value flower came out. There was quite a lot of discussion in countries that relied on cost effectiveness and qualities as to whether there were other elements of value. And indeed, to different extents, different countries allow other elements of value. For example, in Europe, Sweden and Netherlands allow consideration of productivity benefits, whereas in other countries, they're not considered, at least in the main analysis. And if you look at the HEMA paper, they do go through some of the elements of value that have been proposed on the back of the ISPOR flower and in the developing work in USC, to try and make an assessment of whether they feel they can bring these into their decision-making framework in an organized way. And so they ask questions about, what's the level of evidence behind this concept of value? Can it be operationalized in our system? Are we already doing some of it? For example, a lot of these countries that rely on cost per quality have other considerations, which in some cases are called modifiers, where you can increase or lower the cost effectiveness threshold based on other considerations. And I believe ICER in the US had a list of extra considerations to be considered by the stakeholder groups when they were reviewing the evidence. So I think it's been a useful debate. I really do. And certainly Grace has been quite helpful, I think, in putting an economics methodological framework around some of the things that decision makers felt they should be considering anyway, such as, giving a higher priority to very severe diseases. So I think it's good. It's not stalled. I think and the empirical evidence is now coming out, comparing estimates of health benefit based on grace versus orthodox QALYs, and we do see a difference. And a number of commentators like myself have been comparing those differences with what you might get when you add a modifier to a standard QALY, and there's a lot of agreement there. So long may it continue. I understand there may be some more debates in the literature later, but I can't anticipate whether people will be doing that.
And so are you thinking that it may come down where we decide that we agree that there are different value estimations for different sectors or countries with different types of health systems, that may just be the dividing line, and where we agree to pursue different approaches?
Yeah, I think the way I would put that is to say we could probably come up with a common set of potential things you could consider as value, but the local context might determine the priority that those are given to or not. And one might expect in a collectively funded healthcare system like the British National Health Service, there would be less scope to bring in some of those more individualistic, consumer-based notions of value than there would be in a system whereby the patient is paying quite a lot of money, either through premiums or various kinds of co-pays, and have the right to expect that their particular views are more closely reflected in the care that's provided. So I see it not as a schism in terms of what is value. It's more about what do we really think we should include given our local circumstances in particularly the main analysis that we would do of value.
Sounds strangely like all of the conversation around perspective that we had, back in the 80s and the early 90s. I mean, it's just a more advanced discussion of that.
Well, I think having a debate with somebody with a different perspective enriches your own notion of what your perspective is. And, it makes you look for evidence. I mean, I flirted a little bit with discrete choice experiments and that kind of thing. And these do consider other elements of value, like like convenience and so on. But what you consistently find is that the highest consumer weights are put on things like, is this treatment really effective? Is it going to work for me? Is it going to improve my length of life and quality of life? So you don't need to be a quali fan to realize that what people are looking for most from investments in healthcare is to live longer and to have a higher health-related quality of life, although some of these other things are also important, about how they feel about themselves, and so on.
Much of the value debate ultimately comes back to budgets, yet budget constraints are often discussed indirectly or, quite frankly, avoided altogether. Why do health systems and sometimes health economists struggle to have honest conversations about budget constraints and opportunity cost? And can you give some real life examples that highlight how we've avoided this reality?
Yeah, I mean, I think it goes back to what I said before, that everybody's keen to talk about benefits and nobody's keen to talk about costs. And the way these healthcare systems differ is how the opportunity costs manifest themselves, because there's always an opportunity cost to any decision you might make in life,
Mhm.
because in life you're always dealing with scarce resources. So if you commit those resources in one direction, you can't commit them in some other direction. So it's read about how the opportunity costs arise. So in a sort of a publicly funded healthcare system, if there's a very hard budget constraint, that sets the opportunity cost of health.
Mhm.
So, and you might say to yourself, well, that's just as fraught as some of the other approaches, because who's to say that that budget was set at the right level? I mean, it's set exogenously in the UK, exogenously by the political process. And I don't know whether the budget for the British NHS is set at the right level or not.
Mhm.
So the alternative, though, is that there's no obvious budget, sorry, and no obvious opportunity cost, but the rubber hits the road somewhere down the line. So if you take the extreme of private health insurance, um, as an insurer, good way of covering your costs is to put up premiums or copays, and it's only when people sit down at the beginning of the year to decide which insurance plan they're going to stay with, how much it costs, that the opportunity cost against the household budget manifests itself.
Mhm.
So, so it's always there. And I think our duty is to try and point this out when we can. And I think where we've probably not been very good at this is that opportunity cost to many people is kind of a bit of an esoteric concept, and we've got to find ways of expressing it
Mhm.
that grabs people's attention. So, one way I've seen when talking to clinicians is to say to them, well, think about the patient that isn't in the room. You know, you've not just got this patient you're dealing with now, you have a community of patients under your care, and you've got to think of them as
Mhm.
well as the one that you're dealing with now, particularly in terms of the opportunity cost of your own time. So maybe for these big public investments, we should express the cost more in terms of, some examples of what you could have instead of
Mhm.
new therapy, for example,
Mhm.
and what it would mean, instead of saying it's costs so many QALYs or years of life lost, to actually give some examples, what's being displaced at the margin. And certainly in the UK, with the work on cost effectiveness thresholds, there were some attempts to try and get at what was being displaced at the margin, but it was very difficult given the information that was available from the healthcare system. Always the risk that providers who want a bigger budget, when you ask them what they're going to sacrifice, they'll deliberately pick on something of high value.
Yeah.
Say they're going to sacrifice that. So, there's games being played all along here. So, but I think we could do a little bit better in trying to make opportunity costs feel real to people. That doesn't mean that people are always going to take notice. I mean, at the end of the day, you win some, you lose some. And, the people have had the best advice and still made a decision that goes in the face of that advice.
Yeah, I had a few of those in college.
Yeah, your grades are always wrong, right?
That's right. These were not easy to come by, Mike. So the UK government agreed to raise the NICE threshold about 17%, up to 25 to 35,000 pounds, and there were estimates that would therefore could possibly allow 3 to 5 medicines or indications to be recommended per year. And this threshold increase to me suggests that health policy objectives may be expanding beyond just efficiency and equity and more into a country health strategy. Is HEOR being asked to stretch beyond its traditional remit into broader economic and industrial strategy? And are we even equipped to do that well?
Yeah, I think this is a really interesting area, and I'd like to generalize it a little bit from the UK context, but that's kind of what's happened recently. I mean, we had a sniff of this during COVID, didn't we? Where people were talking about the health of the population is maybe not just influenced by what we do in controlling the epidemic within the healthcare system. Things down like lockdown were causing mental illness and so on. So I think there was a bit of a thought by health economists that we need to think a bit broader, even at that point. But the interesting thing about this current debate is that I think it stems from the fact that after the UK decided to leave the European Union, successive governments have been worried about would the UK be sufficiently attractive to get inward investment now that it's not so connected to the European Union, and there were barriers being put up with trade with our largest trading group. So I think the government's been a bit more sensitive to comments from the industry about the fact that they perhaps weren't going to make investments in the UK because somehow the UK was an unfriendly country and wanting these low prices and using cost effectiveness and so on. So what struck me about it was the health economists in the UK, including some of my colleagues at York, did a really good job in pointing out the health consequences of this shift in policy. But it was difficult to make a big impact on the decision making because folks were saying, well, the other side of this is we're going to get more inward investment. We're going to get a better deal with the US for exporting pharmaceuticals, which is one of our biggest exports to the US. And we didn't really have an easy counter to that. And it set me thinking about, should we be partnering more with industrial economists who could perhaps give us some insight in what really drives pharmaceutical investment? I mean, do companies really invest less in a country because it's considered unfriendly from a cost effectiveness point of view, or is it based on things like the skill base, the other taxes and incentives? the location of that country in world markets, transport systems, all kinds of things. And, it did strike me that the Republic of Ireland, which has a lot of inward investment from pharma companies, doesn't have a system far removed from the UK when looking at cost effectiveness. So it just made me think that we may need to stretch out, go outside our typical box in HEOR in certain situations where the debate was a cross-sectoral one. On the one hand, investment in industries and innovation versus, the current healthcare costs and the current healthcare budget. So it's certainly been an eye-opener for me, and I think we may see quite a bit more interest. I'm involved in one European project which has just come to an end on innovation, and one or two of the work packages look at things like how is innovation stimulated both within the public sector and the private sector. Because one has to remember another part of this is that, particularly in the US, a lot of pharmaceutical innovation was on the back of public investments in primary research. I mean, maybe not continuing at the same rate as it was before, but I mean, that's been a big driver of the power base of US pharma, to have that public investment in some of the basic research that underpins pharmaceutical R&D. So I think it's a really interesting interface to examine, and I think it probably will be a bigger feature in pharmacoeconomics in the future. Building partnership with industrial economics.
Do you see some of the academic training that it should be expanded to include more industrial economics, more macroeconomics?
I think for those of us that work in HEOR, particularly on pharmaceuticals, I think we would benefit from a greater understanding of the pharmaceutical industry itself. And, I mean, it's not for me to say, but more transparency in general about things like, investment decisions, pricing, and so on would go a long way, I think, because, we're essentially dealing with the price as we see it, and don't really understand the arguments for those prices or the arguments against them. And, I think it would be useful, certainly in pharmacy schools. I mean, I think in the economics department, if you've got strong industrial economists, that might be a good thing. But in a pharmacy school, I mean, as part of a PharmD, I assume there is already something along those lines, but it'd be very interesting. I mean, these drugs don't come out of thin air, do they? It's
Right. If we are not trained to think in a little bit more of a macro or an interactive way, then essentially all of our health economic analysis becomes cannibalization. We're just moving one thing to another, from one thing to another within the healthcare sector, rather than thinking about the other levers that could be pressed.
Yeah, the changing is, of course, the interest in environmental impacts, because the healthcare system is one of the biggest carbon generating industries, and there is some discussion about should environmental impacts be included in pharmacoeconomic assessments and approvals.
And certainly with AI and the expansive use of that within the healthcare sector now, that discussion is even more prescient, I think, with all of the water usage, et cetera, that AI has.